Hello, my name is Widya Anandita. I'm from YO Academia, Indonesia. And today in the BYOS Academia, we're going to talk about diagnosing POAG. So POAG is a chronic progressive optic neuropathy in adults, where we can find loss of retinal ganglion cells as well as retinal nerve fiber layer that is associated with characteristic morphological changes on the optic nerve head. And it is usually associated with an elevated IOP, and you have to confirm an open angle in gonioscopy. And in 2013, the global prevalence of POAG among adults was 3.05%. And although Africa found to have the highest number of POAG prevalence, but because we have a higher number of people in Asia, so we still have lots of cases of POAG. In the Chennai eye disease study, the prevalence in India is 2.4%, and in a SID study in Singapore, the prevalence is 1.31% in Chinese and Indian and 0.8% in Malays. So there are actually lots of mechanism involved in glaucoma progression and glaucoma incidence. And actually, IOP is just one of them. So IOP-related mechanism include circadian cycle, corneal parameters, including thickness and also biomechanicals and blood pressure. And then there are also non-IOP-related mechanism like vascular dysregulation, hematologic abnormalities, impaired CSF circulation, and structural abnormalities, especially in lamina cribosa levels. All of this that then creating a loss on ganglion cell axons and loss of blood vessels and glial cells. As I said, there are lots of risk factors. The only one that we can control is the IOP, but one of the most prominent one is actually age. So we can see a really exponential percentage of people with POAG, especially with normotension glaucoma as people age. And then there's also race and refractive errors, especially in high myopes. And then in people with low central corneal thickness and also biomechanics of the cornea now play a big roles. And family history, people with POAG has a 40% greater chance to have another person with POAG within their family. So if you have family with POAG, you will have higher risk of POAG. And then migrants also play roles. Dips in blood pressure, especially when you are in supine position. Also, people with low intracranial pressure, as they say, they make a significant difference in pressure gradient between the intracranial pressure as well as the intraocular pressure in lamina cribosa level. This hemorrhage, vascular dysregulation, and also obstructive sleep apnea. We need to also learn about some other terminologies that are related to POAG. First, we have ocular hypertension, and in ocular hypertension, we found untreated IOP more than 21 millimeter mercury, but with normal VF, normal optic disc, and RNFL. And then we have to confirm open angle under gonioscopy without other pathology and no secondary cause of elevated IOP. The risk factor in ocular hypertension are older age, higher IOP, higher PSD in VF, smaller central corneal thickness, and larger vertical cup disc ratio. And then we also have normal tension glaucoma, which is actually a bit controversial. Some people think that normal tension glaucoma is part of POAG. Some would argue that it's an entirely different diagnosis, but it is a progressive optic neuropathy with open angle with IOP within normal range. So we have untreated IOP under 21 millimeter mercury, but with typical glaucomatous optic disc changes and RNFL thinning with corresponding VF defect. There are there are also some that would put patient under POAG suspect. So in APGS guidelines, there were no mention of POAG suspect, but it is stated in the European Glaucoma Society guidelines. And these are the people who have suggestive clinical findings, but still not confirmatory of open-angle glaucoma. So they usually have VF and or optic disc and or RNFL normal or suspicious, with at least one of them being suspicious, and the IOP can be normal or increased. So in patient with POAG suspect, where we still not sure whether or not this is a glaucoma patient, the risk and benefit of treatment need to be weighed against risk of development of glaucomatous disc damage. And we can follow up the patient every 6 to 12 months, and we can recheck probably more often their OCT and Humphrey to actually classify them whether or not they are glaucoma patients. There are also some that would use the term of preperimetric glaucoma. So it's actually an early stage of open-angle glaucoma characterized by structural changes in optic nerve head and RNFL without corresponding functional changes in automated perimetry. So some studies suggest that RNFL loss can be observed in 60% of eyes even 6 years before VF loss. And these are the people whom fall under the diagnosis of preperimetric glaucoma. And especially in us Asian, they say that it is easier to pick up loss of RNFL in OCT because we have higher number of pigments, and therefore we can more easily pick up RNFL defect in OCT, and the higher chance of us meeting patients with preperimetric glaucoma. And it can even happen in patients with normal tension, especially when they are on the older side. So the more older they are, the more possible they are to be normal tension glaucoma. And in this paper from Jong et al. In Korea, shows that during retrospective case series of 71 eyes with normal tension preperimetric glaucoma, 42% ended up progressing. Some of them progressing, they can see it in RNFL, and then some will progress only in the visual field, and 8% progress in both. So we have to be more vigilant in finding patients who fall into this category, because if we can treat them faster, then we can have better outcome. So we're going to see what we can find in physical examination. First, history taking. It is very important. So we can find out the patient race or ethnicity to see how high the possibility of them having open-angle glaucoma. And then we have to also ask about their family history of glaucoma. And then we have to ask about ocular history, one of them being refractive procedures, because we know if patients have undergone the laser vision correction, they will have lower CCT, and that can affect our IOP readings. And then we have to also ask them about about systemic history, including sleep apnea, and if they have cardiovascular disease, including what drugs they are taking and when they are taking them, if they have diabetes, and if they have hypertension. And we have to vigilantly check whether or not they have a history of corticosteroid consumption, not only topically on eye, but also if they have taken them orally, or if they have used it for inhalation, like in asthma patients, because we also have lots of steroid-induced glaucoma cases in Asia. And then we can check their visual acuity and also RAPD, especially to rule out patients with optic neuropathy, And then we check on slit lamp whether or not they have other causes that can trigger if they have high IOP like uveitis, active or past uveitis, and then pseudoexfoliation. And then if they have neovascularization of the iris, and if they have pigment dispersion, you can check for Krukenberg spindle as well as transillumination in their iris and pigment dispersion elsewhere in their eye. And then we can see, we can check their IOP. Although, because we know that there are also high numbers of normal tension glaucoma in Asia, we have to be extra vigilant and not only diagnose people based on the IOP. And then we have to see their gonioscopy to find out if there are other possible mechanism of high IOP in the patients. And then we can also see macular and peripheral fundus assessment to see and check whether or not there are abnormalities like big scars that can be found, and we can see it as loss of RNFL, like notching in OCT. So we have to see like the bigger picture of their fundus, and then we need to check their optic nerve head and RNFL. So this is what we can find in slit lamp examination, and this is what we need to look for. So we look for signs of uveitis, we look for signs of neovascularization, and we look for signs of pigment dispersion as well as pseudoexfoliation. In today we have a lot of devices that we can use for IOP assessment, and the gold standard is still Goldman applanation tonometry. Although now we can use lots of other measurements like the tonopen or eye care, and then pneumatometers and non-contact tonometry. Some that I would like to highlight would be Aura and Corvus, which can show you also the biomechanics of the cornea, and they can give you IOP that is already based on the biomechanics of the cornea, so we can have better readings. And these two are very helpful, especially in patient who has undergone refractive procedures. And then one of the newest one is also dynamic contour tonometry, which look a lot like the Goldman applanation tonometry, but instead they are contoured and have readings with chips, and they have a pretty good reliability. And we have to also aware with lots of factors that can affect the measurement of our IOP, like circadian cycle, and then the corneal parameters, blood pressure, and then Valsalva maneuver of the patient. So if you suddenly find IOP spike in patients that are previously good, especially in young patients, recheck, because if they do the Valsalva maneuver while we do the IOP testing, then it will be off. Age, exercise, especially by dehydration, lifestyle and posture. So if you do it in supine position and while patient sitting or standing, there will be a difference. We can see here the diurnal IOP changes, and we can see from 24-hour monitoring, the fluctuation can be around 6.9 millimeter mercury. So one of the most important assessment in determining whether or not this patient is glaucoma patients or not are optic nerve head and aeronaval assessment. And these are all the things that you can see in patients with glaucoma. So what you want to see is a decrease in neuroretinal rim, and they usually come with, they usually happen first in inferior, superior, nasal, and then lastly on temporal side. And then we can also find a notching optic disc hemorrhage, and sometimes optic disc hemorrhage can also be signs of patient who will have significant progression in the future. And then nasalization of the nerve vessels, and we should not see pallor of color of the neuroretinal rim. If we see pallor, then we need to think of another diagnosis of optic nerve disease. And then we can also see beta zone parapapillary atrophy. So here on the first one, on the top picture, we can see notching. And then on the left one, we can also see a retinal defect. This will be best viewed on rat-free pictures. And then we can also find peripapillar atrophy and neuroretinal rim thinning. And we can see nasalization and vessel bearing, and also bionetting of the blood vessels. Here we can see lots of ways where it can changes from normal age, and if you do not have an OCT where you practice, it's also very helpful to be able to actually measure the optic disc, because it is very easy to find people with large cup disc ratio, and actually diagnosis based on cup disc ratio is no longer recommended, because we will need to actually see if there's a large disc, and you can actually measure it using your slit lamp, and here are the guiding scale on it. This is picture of the beta zone, which you can find in patients with POAG, and also splinter hemorrhage of the disc. On gonioscopy, what you want to find is, first you have to confirm open angle. Although you see the patient on slit lamp and you see like maybe the patient have a von Herrick 1 or 2, sometimes when you do gonioscopy, it turns out to be open angle, and also the other way around. Sometimes you see the patient have a von Herrick of 3, and then when you see the gonioscopy, it's actually a close angled patient. So you have to confirm whether or not this patient have open angles. And then you find other abnormalities, such as angle recess, like the one we have here in the middle, pigment deposition, especially in pigmentary glaucoma, and then also neovascularization of the angle. Usually in the early stages of NVG, you can still find them to have open angle, and you can find neovascularization on the trabeculae. So when you find gonioscopy and you can see all the structure, and then you can use this guidelines to find out whether or not it's OAG. So it's very, very helpful if you have OCT imaging, because it can provide you with objective, quantitative, and reproducible measurement of the neuroretinal rim and RNFL. And there are lots of formats that you can actually use to find to get better readings, but it is sometimes very challenging to interpret. Remember that we compare the patient data with normative data, but we have to see the patient case by case, because not every case would be compatible to be compared with the normative data that they have, like in patient with high myopes. And then we should also see like the bigger pictures. If, like what I said before, if patient has retinal scar of media opacity, it will be harder to get a good imaging. Okay, now we can see some of the examples. So we can see here that there are actually, if you just read the ONR NFL guidance, you will find nothing. But when you see it with more detail, you can find that there's like small defect in the inferior that then correspond with VF defect. So this is a glaucoma case. And then you can also see this patient that we only find the defect using RNFL, GCIPL thickness probability map. So you see that if you just see it in like the big map, it says nothing. But when you see it with the probability map, it shows that the patient actually have loss of RNFL in inferior. And then they also have RNFL optical texture analysis that can show you like a more bigger pictures, like we can see in the example here. And they also have the guided parameter analysis that can show you difference during different timelines, which can help you with see whether or not this patient are progressing, and they can also track you and give you an idea on how the patient will keep progressing on the years forward. And then one of the big things is also perimetry. And what we usually use are standard automated perimetry. We usually use especially in 24-degree or 30-degree, although testing in the central 10-degree is also important, especially in patients with advanced disease or some patient that shows involvement of the central macular area. And now they also offer 24.2C, which can show you your usual 24.2 perimetry with 10 more dots that will represent the 10-degree and can help you see the central area clearly. But one of the main difficulty is to make sure that the measurement is reliable enough, because they are a learning effect where patient will need to take times to actually understand how to do the perimetry to give you a good result. The general rule is to have them do it every 3 months in the first 2 years. So you have 8 measurement before you then establish the baseline for this patient. In Humphrey perimetry, you can also find a glaucoma hemifield test. So when you see perimetry, what you can see to find out whether or not this is a glaucomatous defect is you see the glaucoma hemifield test. If it's set outside normal limits, then it's most probably a glaucomatous defect. And then if you have a cluster of 3 points with a probability less than 5%, including one point with less than 1%, or a PSD with a probability less than 5%. This is some of the typical VF defect that you can find in glaucoma. Usually at first they will have nasal step visual field defect that will turn into arcuate scotoma, and then when the arcuate scotoma is big enough, it will become a hemifield visual field defect. And if you have advanced glaucoma, then you can also have double arcuate scotoma and temporal and nasal defect, and some even you can only find a central island. So when you do a visual field on patient, this one of the steps that you can see the guidelines that you can see to establish whether or not this is a positive diagnosis. So if you find it to be a normal with no structural abnormality, that means it's no glaucoma. But if you find structural abnormality, then retest. And if it is a borderline, then you have to see if there's a corresponding structural abnormality. And if there is a corresponding one, then it is a positive diagnosis. And if it's clearly abnormal with corresponding structural abnormality, of course, it's a glaucoma. But if not, then you have to find other causes of vision loss. And when it's first abnormal, if it's unquestionable, then it is a glaucoma. But if it is questionable, then you repeat, and you can repeat even some more, because like I said, the learning effect is real. So I generally never really trust the first Humphrey, the first perimetry, and I will retest if I have high suspicion of glaucoma. And then if you establish it, then you do staging. And then you can do staging based on the VF defect. In early stage, if you find the MD value of more or equal to -6 dB, moderate is between -12 to -6, and severe if it is -12 dB. So here we have a case of a female. She was 66 years old with high IOP, but controlled with 1 drop. Now in mid-teens with 1 drop, and then CD ratio is 0.7 to 0.8. No visual complaint actually, so she just came in for an eye checkup. And then we see the Humphrey. So this is actually already some GPS summary of some of the examination that is been through. This is, I think, his 6th. So you can see on the first one in 2023, there are defect that's kind of resembling double arcuate. On the right eye, on the left eye, you can see like it's like a severe disease, but the patient has no complaints. And then when we redo it and redo it and redo it again, especially in patients with low socioeconomic background or on the older side, it takes time for them. And then and finally, after 2 years, we find good readings. And this is good because this is the OCT. So from the get-go, we're not very sure about this patient having a glaucoma, and it turns out to be an ocular hypertension case. And all of this will have consequence to the patient because we need to establish the target IOP. If the patient is actually have a severe glaucoma, then I will have to put her under much more drops, which she probably didn't need, and she probably can suffer adverse event from. So you need to be really vigilant and really careful on establishing diagnosis on patients. So take your time. Okay, I think that's all that I can share with you guys. Thank you so much for getting me involved in BYOS Academia. I hope this presentation is helpful. You can reach out to me through my Instagram or my emails, and I will get back to you as soon as I could. So thank you so much for the Bangladesh BYOS Society team. Assalamualaikum warahmatullahi wabarakatuh.